Good morning, everyone. Welcome to today's presentation. I'm excited to be here with you all. Today, we'll be exploring diseases of skin and subcutaneous tissues. This is an important topic that covers a wide range of conditions affecting the outermost layers of our body and beneath the skin. Over the next few slides, we'll look at different skin diseases, their causes, symptoms, and treatments. So, let's get started and dive into the fascinating world of dermatology. Let's take a closer look at the anatomy of the skin and subcutaneous tissue, which together form our integumentary system. The human skin is made up of three main layers: the epidermis, dermis, and hypodermis or subcutaneous tissue. Today, we'll focus on the first two, especially the epidermis, since it plays such a critical role in protection and sensation. The outermost layer is the epidermis, and it's primarily responsible for acting as a protective barrier against the external environment. Think of it as your skin's frontline defense, keeping out harmful substances and pathogens. This layer is mainly made up of keratinocytes, which produce keratin, a tough protein that gives the skin its strength and resilience. Now, the epidermis isn't just a single uniform layer. It actually consists of 5 distinct sublayers. Starting from the outermost, we have the stratum corneum, which is composed of dead, flattened keratinocytes that form a tough, protective outer layer. Beneath that is the stratum lucidum, a thin, clear layer found only in thicker skin, like on the palms and soles. Next is the stratum granulosum, where keratinocytes begin to die and become packed with keratohyalin granules, contributing further to the skin's barrier function. Below that is the stratum spinosum, often called the prickle cell layer because of the desmosomal connections between keratinocytes, providing strength and flexibility. Finally, at the base, lies the stratum basale, which is the deepest layer where new keratinocytes are generated through cell division. Aside from keratinocytes, the epidermis also contains other important cells. For example, melanocytes produce melanin, which gives our skin its pigmentation and protects against UV damage. We also have Langerhans cells, which are immune cells that help defend against pathogens, and Merkel cells, which are involved in sensing touch. Understanding these layers and cells helps us appreciate how our skin functions both as a protective barrier and a sensory organ. This foundation is essential as we move forward in discussing skin health and related conditions. Let's take a closer look at the anatomy of the skin and subcutaneous tissue. The dermis, which is the thicker layer beneath the epidermis, plays a crucial role in providing structure and support to the skin. It's composed of connective tissue, nerves, and hair follicles, all working together to keep the skin resilient and functional. The dermis is typically divided into 2 regions. The first is the papillary layer, which is the upper part. This layer contains small projections called papillae that extend upward and are responsible for creating the ridges and fingerprints we're all familiar with. Below that is the reticular layer, which is the deeper part of the dermis. This layer is rich in collagen and elastin fibers. These fibers are essential because they give the skin its strength and elasticity, allowing it to stretch and bounce back. Finally, beneath the dermis, we find the hypodermis, also known as the subcutaneous tissue. This is the deepest layer, mainly composed of fat and connective tissue, providing insulation and cushioning for the skin and underlying structures. Understanding these layers helps us appreciate how the skin functions as a complex, supportive system that protects and interacts with our environment. Today, I want to talk about impetigo, which is a highly contagious bacterial skin infection. It's especially common among children, though anyone can get it. The main signs to look out for are red sores or blisters that tend to burst open, and once they do, they form characteristic honey-colored crusts on the skin. These crusts are a key indicator of impetigo. The infection is usually caused by bacteria such as Staphylococcus aureus or Streptococcus pyogenes. Recognizing these signs early is important because impetigo can spread easily from person to person. The ICD code for impetigo is L010, which helps with diagnosis and treatment tracking. Overall, understanding impetigo fits into our broader discussion of infectious skin conditions and highlights the importance of prompt identification and management to prevent transmission. Today, I want to talk about Stevens-Johnson syndrome, or SJS for short. It's a serious skin condition that can be life-threatening. Often, it's triggered by reactions to medications, so it's really important to be aware of this. SJS causes painful blisters and sores not just on the skin, but also on mucous membranes, like inside the mouth and eyes. One of the most characteristic features is a rash that starts to spread across the body. As it progresses, it turns into blisters, and then the top layer of the affected skin begins to die and peel off. This process can be quite severe and requires prompt medical attention. In terms of coding, the ICD 10-CM code for Stevens-Johnson syndrome is L511, which helps healthcare providers document and track cases accurately. Understanding SJS is crucial because early recognition and treatment can significantly improve outcomes. So, always keep in mind how serious this condition is and the importance of quick response when symptoms appear. Pressure ulcers, also known as bed sores or decubitus ulcers, are localized areas of tissue damage that occur when soft tissue gets compressed between a bony prominence and an external surface for a prolonged period. This usually happens due to immobility. When this compression occurs, it restricts blood flow to that area, which can cause tissue damage and, if not addressed, lead to open sores. Some common symptoms to watch out for include discoloration, warmth, blisters, open sores, and sometimes pain. Understanding these signs is crucial for early detection and prevention. Now, pressure ulcers develop in stages, reflecting their severity. Stage 1 involves intact skin with non-blanchable redness, meaning the redness doesn't fade when pressed. Moving to Stage 2, there's partial thickness skin loss that involves the outer layers like the epidermis and possibly the dermis. Stage 3 is more severe, with full-thickness skin loss that extends into the subcutaneous tissue. And Stage 4 is the most serious, where the ulcer exposes underlying structures such as bone, muscle, or tendons. There's also an unstageable category, which means we can't determine the depth of the ulcer because of the presence of eschar or slough. That's dead tissue that covers the wound and obscures its true extent. Understanding these stages helps us assess the severity and guide appropriate treatment, ultimately connecting back to our overall goal of prevention and proper care for those at risk. Now, let's take a closer look at the stages of pressure ulcers. Understanding these stages is crucial because they help us identify how severe the injury is and guide our treatment approach. Starting with Stage 1, this is the earliest sign. You might notice skin that appears red or discolored, but there's no open wound yet. The skin may feel warm or firm to the touch, and it's often painful or tender. Recognizing this early stage is key to preventing progression. Moving on to Stage 2, here we see a partial thickness skin loss. This means the top layer of skin has broken down, creating a shallow open ulcer or blister. The area might look like a blister or a shallow crater, and it can be quite painful. At this point, intervention can prevent it from worsening. Stage 3 involves full-thickness skin loss. This means the damage extends through all layers of the skin, possibly exposing underlying fat tissue. The ulcer appears deeper, with a crater-like appearance, and may have some dead tissue or slough inside. Finally, Stage 4 is the most severe. It includes full-thickness tissue loss with exposed muscle, bone, or supporting structures. The ulcer is large and deep, often with necrotic tissue, and there's a high risk of infection or other complications. Remember, understanding these stages helps us tailor our care to promote healing and prevent further deterioration. Recognizing the progression early is essential in our overall effort to improve patient outcomes and reduce complications associated with pressure ulcers. Now, let's talk about non-pressure ulcers, also known as chronic ulcers. These are a different type of wound that don't develop mainly from sustained pressure like pressure ulcers do. Instead, they result from other factors such as poor circulation, venous or arterial insufficiency, or even trauma. The key point here is that, unlike pressure ulcers, which usually occur over bony prominences due to pressure. Non-pressure ulcers tend to show up on the lower limbs. They're often linked to underlying health conditions. For example, diabetes mellitus is a big factor. Diabetes can impair blood flow and nerve function, which significantly increases the risk of foot ulcers. You might also see issues like venous stasis, where blood pools in the veins, or peripheral artery disease, which restricts blood flow to the extremities. Understanding these distinctions is crucial because it helps us tailor our prevention and treatment strategies. These ulcers highlight the importance of managing underlying conditions to prevent chronic wounds and promote healing. This ties into the overall theme of comprehensive patient care for wound management. Let's take a closer look at the coding guidelines for pressure ulcers and non-pressure ulcers. These types of chronic skin wounds are classified within ICD 10-CM Chapter 12. An important point to remember is the concept of laterality, meaning whether the ulcer is on the left or right side of the body. Including this detail in the clinical documentation is essential for accurate coding. When it comes to pressure ulcers, the ICD 10-CM codes are found in category L89. These are what we call combination codes, which means they capture multiple pieces of information, specifically the site of the ulcer, its stage, and in most cases, the laterality. Speaking of stages, there are 4 main stages plus an unstageable category. The stages range from 1 to 4, indicating increasing severity. But what about unstageable ulcers? These are cases where, based on clinical documentation, the exact stage can't be determined, often because the wound is covered with eschar or necrotic tissue, or if it's a deep tissue injury without clear evidence of trauma. Understanding these distinctions is crucial because they directly affect diagnosis, treatment, and coding accuracy. And ultimately, they help us ensure proper documentation and billing, aligning with our goal of delivering the best possible patient care. Now, let's take a closer look at the coding guidelines for pressure ulcers and non-pressure ulcers. Non-pressure chronic ulcers share some similarities with pressure ulcers, particularly in the need to document the site, severity, and laterality. This helps ensure accurate coding and better patient records. Categories L97 and L98 are specifically designated for non-pressure ulcers. An important point to remember is the instructional note that instructs coders to code first any associated underlying condition. This means that if there's an underlying health issue contributing to the ulcer, it should be documented as the primary code. Let's consider a practical example. Imagine a patient with type 1 diabetes who is seen in the clinic. During the exam, the physician notes a left heel ulcer. The skin has broken down into the dermis, but hasn't gone through full thickness yet. The doctor diagnoses it as a diabetic heel ulcer. In this case, the appropriate codes would include E10621 for the type 1 diabetes with a diabetic foot ulcer, and L97421 for the non-pressure chronic ulcer of the left heel and midfoot, limited to skin breakdown. The key takeaway here is to always remember to document both the underlying condition and the ulcer itself, and to follow the guidelines carefully to ensure proper coding. This approach helps in providing a comprehensive picture of the patient's condition and supports accurate data collection for treatment and research. Now, let's go over some important coding guidelines for pressure ulcers and non-pressure ulcers. First, do not code for ulcers that have already healed. It's important to focus on active cases. Next, always code for ulcers that are healing as acute ulcers. This helps ensure accurate documentation of the current status. When there are 2 pressure ulcers at different stages, but located at different sites, you should append codes for both. However, remember that the code for the higher severity ulcer must be listed first. This emphasizes the most critical condition. Similarly, if 2 pressure ulcers are documented at the same site, but are of different stages, you only need to append a single code for the more severe ulcer. These guidelines help maintain consistency and accuracy in coding, and they connect to our overall goal of precise medical documentation. Keeping these principles in mind ensures that we capture the true clinical picture, which is essential for proper treatment and billing.